Now, the next paper titled Real World Experience in Treatment of Eyes with CNVM Switch to Intravitreal Brolucizumab. Dr. Ashapurna borgohain
Yes.
is going to do that.
Yes.
Thank you.
Good evening, everyone. I'll be presenting a study on real-world experience in treatment of eyes with CNVM switched to intravitreal brolucizumab. As we all know, neovascular ARMD and PCV are chronic recurrent diseases. The challenge at present is the burden of frequent injections, and over time, some cases lose responsiveness to the treating anti-VEGF. And very few studies have evaluated the outcomes of brolucizumab in such poor responders. We aim to study the functional and morphological changes in eyes with type 1 CNVM in neovascular ARMD and PCV switched from any other anti-VEGF to intravitreal brolucizumab. Our outcome measures were change in CMT, best corrected visual acuity, subretinal fluid, intraretinal fluid, PED height, choroidal thickness, and mean number of injections. It was a retrospective and single center study which included patients of more than 50 years of age, type 1 CNVM in neovascular ARMD, and PCV with subfoveal polyp on ICGA. Patients who received more than or equal to 3 anti-VEGF before switch to brolucizumab and who had a minimum follow-up period of 6 months after the first dose of brolucizumab. We excluded patients who had any coexistent retinal diseases affecting the macula, previous history of laser or PDT, or previous history of uveitis. We collected patients from the EMR and evaluated their parameters like the OCT parameters and BCVA. OCT parameters we studied from the subfoveal section or section through the polypoidal PED, and we evaluated them immediately before the last other anti-VEGF at the time of switch 1, 3, and 6 months after the first dose of brolucizumab. All the patients were examined under slit lamp for inflammation at first week post-injection and at every visit. Further intravitreal brolucizumab were given on a PRN basis depending on persistent SRF with one-line drop in Snellen's visual acuity, increase in SRF or IRF or both, or presence of hemorrhage clinically. The decision for switch was taken based on inadequate or partial response or no morphological response or patients requiring frequent injections. We defined inadequate or partial response as reduction of 25 to 75% from the baseline, but not total absence in terms of OCT parameters like SRF, IRF, or CMT, and no response as no change or increase in the OCT parameters. We examined 45 eyes of 42 patients. Majority were males. Mean age was 71 years. Mean duration of follow-up after the switch was 10 months. The interval between first and the repeat dose of brolucizumab was 3 months. Pre-switch, around a similar number of patients had received vivacizumab and ranibizumab, followed by patients who had received multiple switches, followed by patients who received aflibercept. The majority of patients were switched because of inadequate response, followed by no response, followed by frequent recurrences. The mean change in CMT post change to brolucizumab at 1 month was statistically significant. Mean change in BCVA from the baseline at switch was a gain of 4 ETDRS letters, and at 6 months it was maintained. At baseline, at the time of switch, around 79.2% of patients had SRF, which drastically changed to 25% at 1 month, and it gradually increased at 3 months and 6 months. However, the BCVA was stable at that points. In terms of in the change in IRF, at switch, 41.7 patients had IRF, which changed to 10.4. And at 3 months, when there was recurrence, most patients were injected, and it reduced to 25%. There was significant change in PED height 1 month after the injection, after the switch to brolucizumab. This is a subgroup analysis of PCV cases where we can see pronounced reduction in PED height. In the right side, in a case of PCV, there is complete collapse of PED after switch to brolucizumab. 2 eyes had complete collapse, 9 had reduction, and 2 had no response. There was significant reduction in choroidal thickness after the switch to brolucizumab at 1 month. And an average of 1.77 injections were needed after the switch to brolucizumab compared to 3.04 injections before the switch within 6 months. There were no safety issues during the follow-up. This is a representative case of type 1 CNVM in ARMD. On the left side, we can see the patient was not responding to multiple doses of vivacizumab and ranibizumab. And after switch to brolucizumab, there was complete absence of fluid, which remained dry even at 3 months and at 6 months. This is another case of PCV where we can see on the right side who had a subfoveal PED with SRF which responded initially to eflibercept, and later on the patient became non-responsive and the patient was shifted to brolucizumab when where the fluid was completely gone with collapse of PED, and recurrence was seen only at 6 months. So reduction in CMT and compartmental fluid like our study was seen in Braille, Shift and Reba study. Reduction in PED height was also seen in Rispoli et al. Study, and a tolerable amount of SRF which was seen in many cases in our study at 3 months was seen in fluid study. There was no ocular events unlike Hawk and Herrier and Braille study. The limitations of our study includes it is a retrospective study and different antivasive agents were used prior to switch, which could have introduced bias and restrict the applicability of the findings. To conclude, in patients of ARMD and PCV switched to brolucizumab, significant improvement in morphological parameters were noted. BCVA gain was seen, which was maintained in further follow-ups. Most importantly, treatment-free interval was longer, thereby reducing the frequency of injections. Thank you.